All right, everyone. So we'll go ahead and get started on chapter 25. This is over gynecologic emergencies. Um, I don't think most students realize that the difference, like you'll hear of like an OB/GYN or an obstetric gynecologic doctor. That's actually two kind of different things. Although this chapter doesn't really just do gynecologic issues in this chapter. But gynecology is related to like anything to do with like the vagina, basically lady parts, right? Vagina, uterus, fallopian tubes, ovaries, not related to pregnancy. So this could be STDs, this could be like prolapses, pelvic inflammatory disease, stuff like that. Now, obstetrics, right? The other side, that's has to do with pregnancy, or even a peripartum, like anything around pregnancy. So that's kind of the division between the two. Now, as I said, OBGYN doctors do both because they specialize in both. Now, there are OBGYN doctors that just do one or the other, or they focus on one more than the other. And so that's just something to be aware of. So away we go. So girls and women in childbearing years may have major gynecologic problems. And this is what, in my opinion, I'm actually not great at OBGYN, but it's something that I want to get better at because, when I did my OBGYN medical school rotations, the doctor said it best. He goes, well, half the world is my clientele. And that's a really good way to think of it. So these are fairly common complaints. They don't always rise to the level of an ambulance or a 911 call, but we do see these fairly often, especially in emergency medicine. Because, and what makes this difficult is the fact that they present very similarly, at least in my opinion, they present very similarly, right, with some of the same issues, right? Excessive vaginal bleeding, vaginal discharge, pain, or usually they have like fertility issues. And so, STDs, of course, go in this realm. But what I'm saying is the complaints, as far as what the patient comes to the clinic or calls the ambulance for, is usually very similar. It's usually vaginal bleeding and or pain. And so you have to kind of use these complex reasoning and algorithms to figure out exactly what it is. But at the EMT level and even the paramedic level, we focus on just a handful of emergency disorders that are very common, or not common, but they're truly life-threatening. And so that's what we'll focus on in this chapter. Now, a quick anatomy and physiology review. So this is just showing you like a dissected version of the uterus and vagina and the ovaries and fallopian tubes. So this is the vagina right here. Okay, these folds are called rugae, almost like the stomach. And so this is the vagina, obviously. And so this area right here is called the cervix. And you would think, well, that sounds a lot like a cervical collar or a cervical C-spine because it means the same thing. It means neck. And so when they talk about the cervix, they're really talking about the neck of the uterus. And so it almost looks like a neck. And so, but specifically what you'll hear in medicine is them referring to something called the cervical os, and that's spelled like OS, like cervical os. And so that's the opening right here. So if you were to look in the cervix, and I'll show you what this looks like on some coming slides, it's like a round hole. And then up through that hole is where sperm, in the case of fertility, would have to travel to come up here and implant in an egg. And so that is this opening itself is called the cervical os. And so, through there, this is the uterus. The uterus is a smooth muscle. It's important to know that. The uterus is a smooth muscle. And so this is obviously has to do with like when we have contractions in child labor. This is the muscle that is responsible for that. This is what's contracting. And so this right here, what they're showing you is the uterus. Specifically, this area right here is called the myometrium. And so over here are these things called fallopian tubes, and they connect to the thing called an ovary. And an ovary is essentially the female equivalent of a testicle. It produces gonads, it produces eggs. So when women are born, they're born with two ovaries, as men are born with two testicles. And these ovaries produce eggs. And, past puberty, every 28 days or so, they should be releasing an egg from this ovary that gets caught up, like this is an egg right here, that would get caught up in these little finger things called fimbriae, and that would travel through the fallopian tube and hopefully, or not, get implanted by sperm. And then if that happens, then you would have a viable embryo, and then it would hopefully implant up here on the uterine wall, and then pregnancy would ensue. And so we're gonna, just like I tell you all the time, everything can go wrong. This is what goes wrong, right? And so we're talking about like, there's issues that happen all along the way of fertility, and every piece of this has its own pathology, which we will talk about. So this is a frontal view. If you were kind of looking on to someone, like looking like at face on with a woman's, lower chest or lower abdomen, I'm sorry. And so something that I don't think students realize, and when I say students, I'm really talking about probably men, maybe women too. But this is the vaginal opening, and here's the cervical cervix and the cervical os. The uterus is kind of like bent at almost like a 90-degree angle, and so that's something to know. Um, so back here's the rectum. Here's the bladder. And so men who are wondering, well, where does the uterus sit? Well, it's pretty much sits where the bladder sits. So if you've ever felt a very full bladder, that's pretty much where one's uterus should sit normally. And so that's just a couple distinctions to make for you there. All right, so we'll keep going. Okay, so the ovaries themselves. They produce the ova, so they produce eggs. Okay, these are a little bit, and I'll show you what these look like. These are like microscopic, of course, little eggs that are that are released every time that ovulation occurs. And so, like I said, these eggs will get picked up here into the fimbriae, into the fallopian tube. Okay, now the ovary and even the egg itself will produce estrogen and progesterone. Okay, and so these both play a role into like maintaining the uterine wall. This has a special layer right here called the endometrium that helps like when someone's trying to get pregnant. And so estrogen, we've probably heard of estrogen before. It's women produce estrogen, but also progesterone. Just break down this word. To gestation means pregnancy, right? And so pro means to promote. So this hormone literally promotes gestation. It promotes pregnancy. And so this is also produced by remnants of the egg called the corpus luteum that helps promote the walls of the uterus to get to where this egg can implant into the uterine wall, and hopefully the patient can get pregnant. So we'll just assume when I'm talking about this, the patient wants to get pregnant, okay? Because that would be an example of how this goes, okay? Now, the fallopian tubes I showed you, these are like actual tubes that extend from the uterus and they terminate like at the ovaries, and there's two of them, like here, right? These are fallopian tubes, and so what they do is they carry the egg from the ovary into the uterus, okay? And so there's little like fingers, fimbriae in there, and cilia, I think it's cilia, they would be moving the egg along. Yeah, it is cilia. They would be moving the egg along into the uterus. So let me just zoom in on this picture. This has way more information on here than you need to know, but I'm just showing it for an example. So what happens is it picks up the egg here, and these fingers grab it, and it'll travel through these little hair-like things that push it along. And then if you get pregnant, it would implant somewhere around there, hopefully. Now, if you don't get pregnant, what happens is it would be expelled along with the uterine lining. Okay, and so that's menstruation. That's when a woman has her period and they bleed, because that would be what most commonly in life happens. I mean, women obviously don't get pregnant every time they menstruate. They might get pregnant only 2 or 3 times in their life. So the uterus itself, like I said, it is a smooth muscle. And so, that's the myometrium of the uterus. And so we have to realize the uterus is about the size of a pear or a fist, maybe even a little bit smaller, but it's not a very big organ normally unless it gets pregnant, it gets huge. And so what happens is you should know that the uterus, a few principles of the uterus. First, it's smooth muscle. Second, it's very rich in blood supply. And third, the myometrium does the contracting, but we really tend to focus on this thing called the endometrium. And so during menstruation, in a woman's cycle, the walls of the inside of here build up. And so the idea is if it builds up, it becomes really rich in blood supply to promote catching this egg and building a baby. And so, progesterone and estrogen are responsible for this, mainly progesterone. And so this is the idea of, and then so you would say, well, a woman doesn't get pregnant. Well, what happens? Well, this would shed. The lining of this sheds because progesterone will drop, and so it won't be able to support the lining of this uterus, and then the woman will have their period. So, that's pretty much all I have to say on that for now. Now, the vagina, this is the lower part of the birth canal, and it would begin at the cervix. Remember, the cervix is right here. This is the neck, and then so it would pass, from that exterior of the body up, into the cervix. So, maybe 3 to 6 inches. I mean, about 6 inches probably, and that has the ability to expand and it'll contract with age and stuff like that. But it's not a huge distance. So, cervical canal is the passageway from uterus to opening of the vagina. So remember this opening is called the os, and so the cervical os. So if you hear me refer to that, that's what I'm saying. Okay. Um, Now I will say, well, we'll talk about this a little bit at the. I think it's the last slide, but this can tear in pregnancy or with sex or whatever. The vagina can tear, especially with old age. So estrogen is responsible for maintaining the vagina uh, lubrication and like moisture and the walls of the vagina as well, like the thickness of the vaginal walls and the rugae. And so, with older age, older women are more likely, as you decrease estrogen and progesterone, the walls of the vagina will thin. Okay, and so that can cause painful sex and stuff like that. So this is the external female genitalia. So it can be referred to as the vulva. This whole apparatus, the vulva. Now, there's so the word labia means lips in Latin, okay? And so there's the labia minora, which would be this part, and then there's the labia majora, which is this bigger part. The urethra, remember the urethra, men have urethras too, they're just a lot longer, is where urine travels from the bladder to the exterior. So in women, this is very small. It's like an inch. In men, this is from the bladder all the way to the tip of their penis. So, the average penis should be like 5.5 inches erect. And so we're talking several more, 5, 6, 7 fold in length. And so what I'm getting at with this is women have really short urethras. And so it is very easy for bacteria to travel from out here, the exterior, up into the bladder and cause urinary tract infection or a bladder infection, or travel up the ureters to the kidneys and cause a kidney infection. So that's a very important pathology to know, that women are at much, 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 much higher risk of getting a UTI than men. Now, men can still get UTIs, and they do. So that's just something to be aware of. And then down here you have the vaginal orifice. So the orifice means an opening. So this is the actual opening of the vagina. And then, so if you were to go exteriorly, it would be vaginal orifice, vagina, cervical os, cervix, uterus, right? That would be the layers that you would be traveling through. The area between the vagina and the anus is obviously where poop is expelled. It's called the perineum. Okay, that's the medical word for that area. There's a lot of slang words. Don't use them. The actual word is perineum. Okay. Now, this is talking about, that was kind of anatomy. Now we're talking about physiology. So, each month there's this level of hormones, mainly, well, the ones we need to know, progesterone and estrogen, that change, that cause menstruation. And this is in an ovulating female, right? So somewhere between the age of puberty, usually around 13, 14 years old, up to about 50. Okay, 50 is where menopause occurs, typically plus or minus 3 years on average. And so, a woman will menstruate, about 40-ish years throughout their life. And so menstruation is this cyclic shedding. The uterine wall sheds that occur approximately every 28 days. Okay. And so something about this 28-day rule, women in the room may laugh at that, right? Women are not time clocks. Humans are not time clocks, to where, yes, there are women that truly do menstruate every 28 days. And then there's some that don't. They may be every 32 days or 31 days, or it may be 27 and 28 the next week. It just varies. Okay. But as the general rule, it's 28 days. Okay. Now, there is a weird word on here that you might see occasionally. It's called menarche or menarche. It depends on who you ask. They sound very similar. And so this is the initial onset of menstruation. So what is menstruation? It's when you start shedding, or it's really the shedding of the walls. But menarche is when a woman has her first period. Again, what age is that typically? Somewhere around 12 to 13 years, typically. Can it be less? Yes. Can it be more? Yes. But somewhere around that, plus or minus 2 years probably. Now, menopause, again, this is when menstruation and ovarian function ceases to function, right? And so what age does this typically occur? Again, textbooks will say around 50 years of age plus or minus 3 years. So somewhere between 47 and 53 years of age, a woman will slow down the regularity of their cycles, and they will go through menopause. This is rather unpleasant for women. It is inevitable. And so there's a lot of hormonal issues that can occur with this, and distress, hot flashes, mood changes, stuff like that. But basically what happens is a woman's born with so many eggs. And after they release these eggs throughout life, throughout menopause and ovulation, or I'm sorry, through menstruation and ovulation, they reach a point where their ovaries just don't respond anymore for several reasons. They're tired, they're burnt out, and they may not have any eggs left, or as many eggs left, to where they don't function well. And so you end up with menopause. Okay. So let me start with this. An important assessment question that I need you to like burn into your brain of how to say this is, what is the first day of your last menstrual cycle? Okay. And so this is an important question. I would say anyone from the age of 8 to 70, you need to be asking this question. I wouldn't say 70, that's a little excessive. Anywhere between the age of 8 and probably around 60, you need to be asking this question. Men, you would be surprised with how women take this as long as you're professional. And so usually I'll just say, ma'am, I need to ask you, when was the first day of your last menstrual cycle? A lot of women will know right off their head, and some of them will have to look in an app or look at their calendar or kind of calculate it. And the reason you want to know when was the first day of your last menstrual cycle is because what happens is it should be 28 days from the very first time they bleed to the very next time they bleed. So that's why we ask, what is the first day of your last menstrual cycle? So don't ask stupid questions like, when was your last period? That doesn't mean anything. Okay, that's not scientific. You would ask, when is the first day of your last menstrual cycle? That's what we need to know. It should be 28 days in between cycles, generally. Okay. Now, this is kind of something I just want to show. You don't memorize this. I'm showing this to you so you can kind of appreciate what's happening here with this whole period menstruation thing. So here we go. Basically, the brain sends out some different chemicals called L8, luteinizing hormone and follicle stimulating hormone. And basically, it does influence the ovaries, okay? And so, an egg will get primed up, and so the egg will produce estrogen, and then it'll rupture, and then it'll produce progesterone, right? And so, what order this comes in is not important. The ovaries and the eggs produce estrogen and progesterone because the brain tells it to. And so what I'm trying to show you is the walls of the uterus, or the lining of the uterus, right? This is called the endometrium, the inside. So throughout the period, when you start having a lot of hormone, a surge in estrogen, especially progesterone, you get a thickening of the walls. And so you get these spiraling of arteries and the building up of the endometrium to help support a pregnancy if it were to occur. And so the idea is that's what's happening. And then if it doesn't occur around the 28-day mark, if it didn't occur, the body says, all right, ejectocito, and the hormones will drop because the corpus luteum can only produce progesterone for so long. And so it'll drop. These hormones will drop. And when they drop, there's not enough hormone there to support the lining of the endometrium, this inside wall. And so it'll shed itself. Okay, and then when it sheds itself, this is where women will bleed from their vagina. And so again, this should happen about every 28 days. So again, don't memorize this per se. I'm just trying to put this into perspective to what it is. Okay, now let's talk about what this slide says. There's something called premenstrual syndrome, or PMS. And so these are symptoms that normally occur 7 to 14 days prior to the onset of menstrual flow, prior to bleeding. And so, the reason this is because, look, this is the 7 to 14 day mark here prior to bleeding, which is here. And so the reason that they get this discomfort and dysphoria and change in mood and irritability and sleep disturbances and weight gain and all these issues that can occur, the reason for that is their hormones are surging. And so, it's not, there's stereotypes of this, but really it is uncomfortable for some women, some more than other, to where it becomes disorderly. It affects their daily life, right? They'll get cramping, not cramping per se, but they'll get just irritable, okay, and unpleasant. So, just something to be aware of. That's called premenstrual cycle or syndrome, excuse me. And so once the bleeding starts, the hormones have already dropped, so they're typically not upset or irritable or hurting at that point, okay? Now, stress, diet, alcohol consumption, and prescriptions or non-prescription drugs may exacerbate these symptoms. You'll see that, gynecologic emergencies and really just women's health is greatly hormonally influenced, more so than men. And so, you have to think of anything that can stress the body: illness, physical, emotional stress, changes in environment, heat, cold, pregnancy, all these issues, thyroid, endocrine, diet can all change fat. These can all exercise. These can all change the way a woman's hormones work. And so you can have, all these issues that'll present with that. Okay. Now, this is a weird word called Mettler's. And so basically this is abdominal cramping in 2 weeks before the beginning of menses. And so this is pretty severe cramping. Some cramping is to be expected, but this is severe, okay? And so this is like disorderly. And so basically what's happening is they're filling the cramping of the egg rupturing into the fallopian tubes, and so or the rupturing from the ovary and then being picked up in the fallopian tube. And so, they'll get sharp, crampy pain in the lower abdomen. It usually will locate to one side because you really what should happen is only one ovary should release one egg at a time. That typically doesn't happen always, but that's what's supposed to happen. And so this is called metal schmers. So if you hear someone that says, hey, 22-year-old female, she's having severe crampy abdominal pain, her last period is 2 weeks ago, or the first day of her last menstrual cycle was 2 weeks ago, what is it? Metal schmers would be a realistic diagnosis for this. Okay. Now, amenorrhea literally means without bleeding. Okay, so a means without, so it's without menstruation, and so amenorrhea is the absence or cessation of menses. So the most common cause of this is pregnancy. You should not be bleeding or having a period in pregnancy. If you do, that's probably an abortion. And so, let me clarify. An abortion does not think of what the news tells us, right? Abortion means a miscarriage. That's a medical word for miscarriage, okay? What the news and but you may think of the word abortion would be what we would call a medical or a elective abortion, okay? But anyways, an abortion can mean miscarriage. And so, where I'm getting at with this is anytime a woman says like, oh, I missed my period, you need to be thinking, oh, you're probably pregnant. That would be the most reasonable cause of missing a period. So if a woman tells you, hey, I have my period every 28 days and I haven't had a period in 2 months, the very first thing you should be thinking is, oh, you're probably pregnant. And so, a pregnancy test would be a very good test to have at that point. Now, a reasonable question that you can ask as an EMT is, are you sexually active? And if they say yes, do you use protection? Do you use condoms or birth control? Or do you have an IUD or whatever, or, condoms? And if they say no, then, there's a very likely chance they're pregnant. So just keep that in mind. Amenorrhea is most commonly caused by pregnancy. And so, but you can get this thing called exercise-induced amenorrhea, and it's usually common in female athletes, especially young ones, or you also see this in anorexia nervosa, or even bulimia nervosa. So what happens, more so anorexia, so what happens is estrogen is, just fat on our bodies, men and women, produce estrogen, okay? So when testosterone comes, or hormones, androgens come in contact with this fat, there's these aromatases, and so it will convert androgens into estrogen. And so when a woman has like a really low BMI, meaning they're very, very skinny, they don't have that excess estrogen that's being produced by the fat of their body. And so again, this jacks up their hormones and then they end up not menstruating, okay? Now, also with that, women can also have amenorrhea, meaning they don't have a period, they don't bleed as they should, because of extreme emotional or like physical stress, okay? So I've actually seen this in a friend that she I'll tell you, as a medical student, and she decided to share with the class that she hasn't had a period in a long time. She wasn't pregnant because of how much stress medical school had put on her. And so, women have probably experienced this before with extreme life stress, but it's just something to be aware of. And again, the reason for that is cortisol is produced as a stress response, and so this cortisol can again jack up the hormones of a woman, and then they don't menstruate as they should. Okay. Now, disorders in the female reproductive system can lead to gynecologic emergencies. We're really here for the gynecologic emergencies. That's what us as EMTs and paramedics do. So, we see different varieties of why this happens. And so it could be acute or chronic infection. We'll talk about these. Hemorrhage, remember, hemorrhage is to bleed. Rupture of a cyst, we'll talk about what that is. And rupture of ectopic pregnancy. And so these are all, some of these might sound like foreign words for now, but we'll talk about exactly what they are in this video. These are commonly tested, by the way. We'll start off with something called pelvic inflammatory disease. This only happens in women. And so it's basically where you get chronic, it can be acute or chronic, but to get the true PID, it's usually chronic, where you get this infection that's ongoing, usually an STD, namely chlamydia or gonorrhea, that will cause this long-term infection. And your body's response to infection is scarring, okay? And so if you get, like, for example, a smoker, right? They're constantly smoking where your lungs get scarred. And so, that would be from all the infection and the toxins and the irritants. Well, the same thing can happen in the pelvis because of chronic infection and inflammatory response. again, namely, usually due to gonorrhea or chlamydia. Those are both STDs. And so the chief complaint is pelvic pain. It hurts in their pelvis, their lower abdomen, and fever because there's inflammatory response and infection. And so you can get some, this is very serious. And so the complications can include sepsis. Remember, sepsis is overwhelming infection throughout the body. This is remarkably lethal. Abscess formation. Abscess formation is like essentially a pimple or like a boil that's walled off. So this is an infection that's walled off is the better way to say it. So you can get like a tubo-ovarian abscess. This is a surgical emergency. You have to go in there and surgically drain this. Um, Generalized peritonitis. So remember, the lining of the inside of the abdomen has this lining called the peritoneum. And so when this gets inflamed, whether it's through infection or in contact with blood or whatever, a stabbing or whatever, it hurts, and it gets inflamed. So that the peritoneum, when it gets inflamed, is called peritonitis. This is remarkably painful. And I'll tell you, it presents with a phenomenon called rebound tenderness. And so if you were to press on someone's abdomen and quickly let go, what happens in peritonitis is pushing might hurt, but it's the when you quickly let go, that bouncing of the peritoneum that hurts even more. And so that's called peritonitis. Okay, I'm on call. I'm just checking my phone. Okay, and you can get infertility from this, and I'll show you what this looks like. Okay, now we're going to talk about well, I would say some STDs can cause this. Again, namely, it's gonorrhea and chlamydia. But STDs cause peritonitis or cause pelvic inflammatory disease. So for now, we'll talk about some of these sexually transmitted infections, namely in women. Now, men can get almost all of these as well, so that's worth knowing. Okay, and let me tell you this: one in five. Okay, half of the. This is mind-boggling to me as a man, but it's important to know. This is general pathology. Um, Okay, around 40 to 50% of women who have a chlamydia or especially a gonorrhea infection don't know. They don't have symptoms. Okay, and so that's how pelvic inflammatory disease can happen because you're like, what the heck? How do you not treat chlamydia or gonorrhea? How'd you not know? Well, they don't know. And testing for this is not easy, right? You can't it's not easy to get a test for this at home right now. Um, and so this is the problem with these STDs. And so, people that engage in promiscuous sex or condomless sex or frequent sex or sex with the same sex, like men having sex with men or, sex with multiple partners or sex with sex workers. These are all high risk sexual behaviors where you should get tested frequently because again, you could have an STD, the patient could have an STD and not know it. And so this is an important general concept to know that, about more or less half of the patients that have an STD don't have symptoms. And so that's very important to know. So off we go. So treatment involving placing the patient with an STD in a position of comfort and providing supportive care. Remember, patient positioning is an intervention. And so, bacterial vaginosis, this is sometimes called by providers BV. It's basically normal bacteria in the vagina. So normally there's normal bacteria flora, and this can be replaced by an overgrowth of certain bacteria. Okay, and so this can happen for a variety of reasons. And let me tell you too, it's not necessarily a hygiene issue that this can happen. It just happens sometimes. Really, it has to do with the pH of the vaginal canal. And so the pH of the vaginal canal is very sensitive. And so women that douche or, again, sexual behaviors, this can throw off the pH of the vagina, or poor hygiene too, can throw off the pH of the vagina, and then they get a bacterial overgrowth of what the normal flora is, and then it dominates, and then you end up with bacterial vaginosis. And so the hallmark of bacterial vaginosis is itching and burning, and so it's uncomfortable for patients. And so it can also have a smelly discharge. It's not a stereotype. It does have what's called an amine odor, which can be referred to as a fishy odor. The literature calls it that, not me. So that's worth knowing. That is not just a stereotype. It can be referred to as a fishy odor or an amine odor. And I guess we could talk about the elephant in the room or the cervix in the room, and that's this. And so this is a cervix, okay? And so you're looking through the vagina with a speculum. We don't do this as EMTs or paramedics, but I'm just showing you. And so you're looking through the vagina at the cervical os is right here. And so sperm would have to travel through here up into the uterus and hopefully meet with an egg to have a pregnancy. And so, this is probably showing you something like candidiasis or maybe something else, but this is obviously a white discharge of the vagina. And this one's more probably showing you like trichomonas or bacterial vaginosis, probably. I'm going to say this is actually BV, caused by Gardnerella vaginosis. This is caused by bacteria. But I don't really know. I don't remember which these captions were. I'm just showing you what a cervix looks like that is infected. It should not look like this. Okay. And so more on STDs, that you can get something called a chancroid. This is fairly rare, but it's caused by a bacteria called Haemophilus ducreyi. Um, and so it has rolled up edges and it is exquisitely painful, so I'm told. And it's very, very painful. So it's an ulcer that is painful. And one way I remember this in medical school, you probably don't need to remember this, is Haemophilus ducreyi will make you cry. So if you have Haemophilus, you do cry because it hurts. And so women can get this on their vagina, and men can certainly get this on their penis. And so this is showing you what a chancroid looks like. Okay. Now, chlamydia is fairly common. Not it's not as actually it's the most common. What am I talking about? Chlamydia is extremely common. It is the most common STD out there, other than HPV, and so it is very, very, very common. And so it's like got a sevenfold prevalence over gonorrhea. And so the good thing about chlamydia is it's very easily treated with one pill called azithromycin. And so chlamydia will cause like a watery white discharge from the tip of the penis or from the cervical open or from the vagina. And so again, only about half of women, if they have a chlamydial infection, know they have it. And so this is why it is important to know or to get tested if you engage in promiscuous sexual activity, frequent sexual activity without protection, or if you engage in sexual activity with a sex worker. Okay, and so again, this is chlamydia. Very, very. I'm saying very, very common. It is very common. Of the STDs other than HPV, it is the most common. Okay, by like a sevenfold. Now there is this virus called cytomegalovirus. The problem with CMV is really it can cause it's part of the herpes family, but it causes it can cause birth defects for babies. Okay, and so it causes like these prolonged illnesses in women too. And so it's a common viral infection. We don't have a cure to this, and so it causes what prodromal syndromes, right? To where it's just kind of general, right? High fever, chills, headache, malaise, which means like tired and weakness, extreme fatigue, and a large spleen. And so where does the spleen sit, student? It sits in the left upper quadrant underneath the rib cage. And then a large spleen will grow in the direction towards the right lower quadrant. So if I'm drawing this on myself, it'll grow in this direction. And so that's just something to know. That's called CMV, or the cytomegalovirus. Okay. Now, genital herpes is actually fairly common. Around 80% of the population is some type of herpes seropositive. Doesn't mean they have genital herpes. But these are obviously going to be this is a cold sore, essentially, that you've probably seen someone or even experienced a cold sore on the lips. Well, these are the labia, right? These are still lips, just not the lips on the mouth. And so you can get herpes 1 or 2, and it doesn't really matter to distinguish between the two, but there is a treatment for this, but there's not a cure. And so you can put medicine like valcyclovir, cyclovir on these in like a cream or a pill, and you can knock down the severity of these, but it's highly, highly, highly contagious. So, if a patient were to have sex with that picture, they're gonna have the same issue. And so when there's active lesions like this, it is outrageously contagious. Okay. And this is, not to be rude or to shame anyone, but this is like kissing someone with a cold sore, having sex with someone with herpes, like active lesions on the anus or on the vagina or the penis. Very, 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 very contagious. Okay. And so one thing I'll say about herpes is it can be anywhere, but we tend to see it on the lips, like the oral lips, the vaginal, or like the opening of the vagina, so on the labia minora, labia majora, the perineum, the buttocks, the anal area, and the penis. Okay. Now, gonorrhea, this is again a bacterial infection other than HPV. In order, it'd be HPV, human papillomavirus, and then chlamydia, and then gonorrhea in occurrence. So gonorrhea is fairly common, but again, it's easily treated. For now, it's easily treated with an injection or 7 days of doxycycline, or a pill for 7 days. And so, this presents very similar to chlamydia, and it's going to be a whitish, watery discharge from the penis with urethritis, so pain with urination. It may feel like they're pissing lava. And so it's a bacterial infection. And again, this can cause pelvic inflammatory disease, and it can cause urethritis, where it burns to pee. And so Now, one thing to know about Neisseria gonorrhea is it can grow in the mouth. And so if someone engages in oral sex, male or female, it can grow in their mouth and throat, and so it can cause these issues. And so you can get this in the you can also get this in the eyes, the newborns, especially without prenatal care, they can get it in their eyes, or again in the anus. Okay, and so the one in the anus, you'll have the patient complaining of pruritus and pain with defecation typically. Okay, and so if the patient is not treated, the bacteria may enter the bloodstream and spread to other parts of the body. This is called seeding. This is exceedingly rare, but it can happen. And so that's something to know. I mean, if that happens, you're going to be looking at sepsis or other disorders. Okay. Again, that would be rare, but these do happen, and so just worth knowing. You can treat this with a single injection of Rocephin. Now, genital warts. This is the most common STD in the world, especially in the United States. And so, women over the age of 16, I think around 13 years of age, they're supposed to get the HPV vaccine because this causes a very high incidence of cervical cancer. And so this is a form of cancer that's fairly difficult to detect. This is why we have pap smears in women, where we take cells from the cervical opening and look at it underneath the microscope. But what we're really looking for with a pap smear, if you ever heard of that, is HPV, because it causes cervical cancer. And so a lot of times the woman will have no symptoms. And again, this is why we do pap smears, routine pap smears. So it's, in fact, pap smears is the single greatest form of secondary prevention that the world's ever seen. And so this has saved a lot of lives in women by doing this. And so women, if you're on the chat, do your pap smears as you're supposed to, because it's very important. And it's a very, very common STD. And so the problem with HPV is it can also pass to the virus, and you can also get, this is rare, but you can get a thing called a laryngeal papillomatosis. And so this is where you can get these warts on the larynx. And where we're more concerned is when this happens on a baby or on a fetus, because if you could imagine a wart on the vocal cords of a baby, that's a problem. And so this creates problems for babies. And so, I mean, women are tested for this in pregnancy. There's a little bit of a treatment, and there's not a cure for HPV. Just like most viruses, there's not a cure. And so that's just something to be aware of. This is why we have a vaccine for this. Now, men can even have this vaccine as well, especially men who have sex with men. But this is a very, very common STD. Now, syphilis. Fun fact, this is what killed Benjamin Franklin. So this is treated with penicillin today. Penicillin is extremely effective. And so the bacteria name for syphilis has a weird name. It's called Treponema pallidum. And so syphilis can mimic a lot of other diseases. I mean, a few things that you should know is it is an STD. It's not extremely common, but there's an increased prevalence and incidence of this right now in the United States. Especially, yeah. And so we'll just say that. And so again, it can present with watery discharge of the urethra or the vagina and a rash. And so there's different stages of syphilis called primary, tertiary, or primary, secondary, and tertiary syphilis. You don't need to know what these stages are, but syphilis can be very fatal, especially over a period of years if it's untreated, which is crazy. You're like, oh my God, it's just penicillin. It's not that hard to treat. I'm with you. I agree. So again, this is why people have to get tested. But the hallmark, I would say a thing to know if you want to know something about syphilis, especially secondary syphilis, is you can get a palm and soles rash. Okay, there's only a few disorders in the out there that cause palm and soles rash. Kawasaki's disease would be one. Syphilis would be the other. Rickettsia would be the other. But really, it's pretty rare to get a palm and soles rash, and so syphilis does this. Okay, and so you can also get like a huge lymphadenopathy in the lymph nodes, both in the throat and in the groin. And you can get these things called gummas. These are pain. Okay, these are actually called chancres. They can progress to a gumma, and so these are painless. I guess that's one thing I could tell you too about syphilis is they're like chancroids where they have these rolled up edges, but they're painless. So I'm going to give you a medical school vignette. You probably won't get tested in CMT school, but 22-year-old male has an ulcer on his penis that's painless. It's syphilis, okay? Because that's pretty much the only one that'll do that, to where they're painless. So syphilis does cause painless ulcers, both in women and men. Now, one thing I'll say about syphilis, in the late stages, it causes things called tabes dorsalis, where the bacterial, the pathology will cause, I should say, issues in the spinal cord where they lose proprioception. So they're almost like kind of drunk. with their spinal cord to where they don't know it messes up their spinal cord basically. So that's something you could know. But again, the patient can be asymptomatic for years. This is again why it's important to get tested if you engage in high risk sexual behavior. Now, this is trichomoniasis. It's caused by a bacteria called it's actually a protozoa, excuse me, called Trichomonas vaginalis, and so it creates a hallmark. We'll change it to green, frothy yellow-green vaginal discharge with a strong fishy odor. Okay, occasionally you'll hear it's called an amine odor, amine, amine. And so this is it also causes a strawberry cervix or a bright red cervix. And so it's fairly, I mean, it's common, it's easily treated, it stinks, okay? And so usually women will get this treated fairly quickly because of the odor and the discomfort. But it can cause a condition called dysuria. Dysuria means pain when urinating. Okay, and so this goes along with what I was talking about earlier, urethritis, but dysuria means pain when urinating. So it kind of burns when they pee, or it hurts, or it stings. Feels like they're urinating lava, something like that. And so, just to be aware, trichomoniasis can cause low birth weight or premature birth and increases your susceptibility to HIV infection. In fact, all of the ones I just talked about can do that. I should say all of these STDs can cause a low birth rate, a premature birth, increase your susceptibility to HIV and other STDs. The reason for this is because you have bleeding with sex. And so when you compromise the lining of the genitalia, male or female, you allow blood to come out of whatever person. And so it's easy for bacteria and viruses to then implant into your blood. And so this is why you have a much higher risk of STDs in men and women that have prior STDs. So that's just something to know. Probably won't get I mean, it's just kind of random, but now this is very, very, very common. And in fact, I would say probably every woman in the world has probably, at least if you're watching this video, has probably had some type of yeast issue with their vagina. And again, the vagina. So normally there's a normal yeast that exists on our skin and in the vagina of women. When there's overgrowth of this yeast, that can cause a vaginal infection or fungal infection of the vagina. And so we call these vaginal yeast infections, or they'll just slang it as called a yeast infection, and you just assume, okay, that's probably in the vagina. And so this will cause what's called a cottage cheese-like discharge. And so again, where you'll typically see this, the hallmark of this is someone that had a UTI and they took antibiotics. And so when you knock down the normal bacteria in your vagina, it changes the pH to 1, and 2, it allows the yeast to thrive, and so you'll get a yeast infection. So it's very common when, like as prescribers, when a woman has a UTI or an STD, to also give them an antifungal that they'll take at the end of their antibiotics. Excuse me. Okay, so if the vagina becomes less acidic, meaning the pH rises, so if instead of like whatever the normal pH, I think the vagina is like normal, like 7. If it rises, the yeast population may increase dramatically, and this causes infection. So it burns, and then it itches, the vagina itself. It burns, it itches, and they'll have a cottage cheese-like discharge. And that's what they're showing you here. This is yeast right here. This is yeast. This is the cervix. And so that's just something to know. And so symptoms include itching, burning, soreness in the vagina and around the vulva, vulvar sweating, white vaginal discharge, pain during sexual intercourse. That's called, oh shit, I can't remember. Dyspareunia, I think. I'd have to look that up. And burning on urination. Okay, the last one, burning on urination, called dysuria. Okay. Gosh, I can't remember what pain on intercourse. I think it's dyspareunia. I think. Anyways, someone look it up. Let me know in the comments. Pain during intercourse. And so that's STDs. And what I want to say about pelvic inflammatory disease, going back, is you could imagine these bacteria, again, namely chlamydia and gonorrhea, that half the women don't know they have this infection, building up. And let me go, what slide are we on? 22. Let me show you something really quick to drive this home. I had to do a whole big presentation to an OB doctor during my medical school about PID. So that's why I'm telling you about this, but it is important. Something you should know is if I were to inject dye, like as a doctor, not as an EMT, dye into the uterus, it'll spill out into the uterus or out into the abdominal cavity. That's normal. So this is like an actual opening here. And so you can imagine someone gets an infection here, chlamydia, and it travels and it eventually falls out here into the abdomen. This then it becomes very hard to treat this because then you have chlamydia and gonorrhea floating out in the abdomen, and so it exceeds and it causes all this inflammation and issues, and that's the issue with pelvic inflammatory disease. Okay, so that's kind of what I'm trying to show you is this is the issue of pelvic inflammatory disease. Now we're going to come back to this. I don't know why they come back to it later. It's kind of out of order, so excuse me. There's this thing called a ruptured ovarian cyst. Okay, so the ovaries, imagine like for men and women, I'm not trying to leave you out on this. I'm trying to relate to men because that's half our audience, that I think they need to have a better understanding of this. So pardon some of my analogies and comparisons, similes and metaphors. And so what I'm saying is men and women, you have these ovaries. Well, you can get these things called follicular cysts. In fact, these are fairly common. And so you can get a cyst, like a fluid-filled sac, okay, on the ovary. And these cysts can be numerous. That's called polycystic ovarian syndrome. You see this in overweight females. Again, it's that whole overweight estrogen issue. But you can also just get this randomly. Like healthy, normal women can get these. And these cysts can get huge, or they can be numerous. And so what happens is you get these follicular cysts that fill with fluid. And I've seen these like with my own eyes during surgery. And we just drill them out and drain them. And so what I'm saying is this can cause pain. And so this is a normal ovary over here on the right ovary. This is the fallopian tube. Here's the fembrae. This is the uterus. You're looking down into someone's pelvis like this. So if you're taking a camera like through the belly button and looking down. And so right here, this is the ovary and the fembrae right here. This is this huge left ovary, and that's a huge cyst. It can be a lot of different stuff in there. You know, I would say most commonly it's just fluid, but it can be blood, and it can be a baby technically, but or parts of a baby. And so, anyways, there can be a lot of things that fill up the cyst, but sometimes you have to surgically remove this. It can cause discomfort for the parent or for the mom. I'm sorry, the mother, the lady. One, and then two, it can cause infertility issues. So again, these can get really big. Now, these do have blood supplies, and so they can bleed. And so if this were to rupture and it was rich in blood supply, it can cause bleeding, and then that bleeding can bleed into the cavity, and then you get shock, and then internal bleeding and hemorrhage. And so this can cause peritonitis, infection, and all these issues. So it's just something to know. It's called a ruptured ovarian cyst. Okay, fairly common. Okay, now there's this thing in medicine called ectopic. Okay, let's just stop. Ectopic means it's out of place. Okay, we get this when you go to paramedic school. You learn about ectopic beats of the heart. It means an out of place heartbeat. It's kind of it's like if, your heart's like normally beating. It's like a thump thump. Those are ectopic beats, the ones that are out of order. Okay, and so we get these things called ectopic pregnancies. And so this is a pregnancy. This is when a sperm has joined an egg, but it's in the wrong place. Okay, and it implants in the wrong place. And so this can occur anywhere out of place. Where should pregnancy regularly implant? Somewhere in the uterus. But where it most commonly happens in ectopic pregnancy is a place called the fallopian tube, specifically the ampulla of the fallopian tube. So let's zoom in and enhance. Now, this is the ovary. So this is crazy to think this has to happen every time someone gets pregnant. Okay. Now, sex occurs, male ejaculates, the right time of the month for the women to where they released an egg. Okay. It's usually the middle of menstruation-ish. Really, I'd say really past the first 7 days to the last day right before menstruation, bleeding, you can get someone pregnant, right? An egg can get implanted. And so really up until the point that they bleed, you can still get pregnant. And something to know, man, sperm can live for 7 days, okay? So in this cavity, so, I mean, someone's going to get pregnant 7 days after you've had sex, okay? And so that would be something to keep in mind if you don't want to get someone pregnant. And so what back on topic, what happens is sperm is ejaculated, okay, in the vagina, and it travels to the cervical os, and it has to travel all the way up to about here, okay, all the way up to the ovary. And so this is typically where implantate or where fertilization occurs. So if this is an egg, a sperm has to swim and penetrate through the lining of this egg and fertilize the single egg, okay? And so this typically occurs about here. Well, okay, what happens after this is this egg has to travel by these little cilia, these little hair-like things that are moving the egg along to where this egg in the next few days needs to travel out of this tube and implant somewhere up here in the endometrium of the uterus. And so what happens is the egg will travel and what normally happens in pregnancy, and again, it'll implant like right here. This is what normally happens. Well, what happens in ectopic pregnancy is the egg got implanted right here. You know, the egg and the sperm joined, fertilization occurred, and so then what happens is it'll get stuck here. There's a variety of reasons why this will happen. The first one is simple physics. This is a really sharp turn to make, okay? And so if this gets kinked or it's too sharp of a turn, it won't make it, okay? That's the most common reason this will happen. The second most, actually the most common reason this happens is pelvic inflammatory disease. So if this is all scarred up, right, like literally scarring, imagine like a scar, if I were to cut you a scar, if this was all scarred up and hard and rigid, it's hard for this egg to move, okay? And so that's pelvic inflammatory disease, the most common cause of ectopic pregnancy. Okay, excuse me, my throat was dry. Now, the second most common cause of it, well, there's a few other causes of this, but that's kind of what you need to know, is that the egg gets stuck here. Namely, test question, I swear to you, test question is in the ampulla of the fallopian tube, okay? Ampulla is this section right here is called ampulla. It's where it makes the turn. And so what happens is this egg grows, right? Because the fallopian tube does have a blood supply to where it'll grow and grow and grow to where it can get so big you can rupture the fallopian tube. This is not the uterus. This is a tube. And so as you start growing a friggin' baby in a tube, the tube can rupture. It'll blow up, you know? And so this is an ectopic pregnancy. It's a pregnancy that's out of place. And so this picture right here, again, you have a camera from the belly button looking down, okay? It's the top of the uterus right here. This is a normal ovary over here. These are the fallopian tubes. There's like the cervix. This is a uterus. This is a friggin' baby, an ectopic pregnancy. Not a very small fetus, you know, probably like less than a month old, probably just a few weeks. That is in the fallopian tube, and you can even tell it's in the curve. This is curved. It's the curve of the fallopian tube called the ampulla. And so this is an ectopic pregnancy, and you're like, all right, Hunter, enough of your nonsense. Well, this is very important. You do need to know this, I swear. How this presents is very important right here. This will show up on exams. I promise you. This is very, very commonly tested. How this presents is internal bleeding or bleeding. You can even be vaginal spotting within the first semester of first semester. I'm in school too long. The first trimester of pregnancy. Okay, so within the first 3 months of pregnancy, first 90-ish days, but usually way before that. And so, or 20, what am I talking about? First trimester, yeah, first 20 weeks of the pregnancy. And so what will happen in this is the baby will grow and grow and it'll rupture this tube. So this presents with bleeding in the first trimester of pregnancy is how it'll almost always present, and it can present with peritonitis. You can actually see blood here. This is blood inside the internal cavity, and this lining right here. Again, this is the peritoneum, and so it gets inflamed when blood or pus or bacteria or something touches it. It gets very inflamed and it hurts. And so how this will present is lower abdominal pain and sometimes spotting. The word is called spotting, like a spotting or vaginal bleeding within the first trimester of pregnancy. And so now with this, you can still actually have a positive pregnancy test occasionally with an ectopic pregnancy. So the woman may be like, oh yeah, I'm pregnant. You know, I had a positive pregnancy test and blah, blah, blah. And, you know, and they didn't realize it had implanted in the wrong place. So this is an ectopic pregnancy. And so the risk of this is if this ruptures, this fallopian tube ruptures, it's a true surgical emergency because it will bleed and bleed and bleed and bleed until the patient dies. And so the only way to fix this is to surgically go in there with cameras and sutures and fix this and sew it up and remove this. This baby will be dead at this point. To remove that, you know, unfortunately, and to sew this up or burn it or whatever you got to do to get the bleeding to stop. And so true surgical emergency. So you're like, oh God, Hunter, it's enough about ectopic pregnancy. You will be tested on this. And so to recapitulate, how this will present is lower abdominal quadrant pain in a woman of childbearing age. And so the classical vignette, 22-year-old lady, sexually active, hasn't had a period in 6 weeks. Today she presents with excruciating right lower quadrant pain, guarding, rebound tenderness of the lower abdomen, and spotting, vaginal spotting. And so you need to think, oh shit, that is an ectopic pregnancy. And so it is until proven otherwise by diagnostic imaging. And so what the reason I'm telling you this, student, something very important, a concept to know is, me as a male, if I have right lower abdominal quadrant pain, it's probably appendicitis or something to that effect, more than likely. Uh, in a woman, it's probably appendicitis or an ovarian cyst or an ovarian torsion or an ectopic pregnancy, right? So they have lady parts there to where you really have to start thinking. There's a lot more anatomy and pathology and pathophysiology that can occur there. And so this is a very important thing to look for in vignettes. When they tell you it's a female, especially a female of childbearing age, with childbearing age, anywhere between the age of 8 and 60, you need to be thinking they could be pregnant or they could be childbearing. It's something to think about, okay? Now, um, this is what I was trying to show you earlier, is the causes of an ectopic pregnancy is usually due to scarring. And so if you've had like past C-sections, like a cesarean section, there's a lot of these things are called adhesion. See these little clear things? These are the arch nemesis of surgeons. I'm doing my surgery rotations right now. I'm almost done. And so anytime you have type of surgery in the abdomen, you get these things called adhesions. And so they're almost like little gluey things that this is a great example to where things stick together. And so this is an adhesion here. And so this is from pelvic inflammatory disease, or this could also be from surgery or something to that effect. And so this is like scarring essentially of the internals of the abdomen. And so if you have had previous any type of surgeries, whether it's an appendectomy or, a cesarean section, or you've had an oophorectomy or whatever, you can get adhesion. So that increases your risk of ectopic pregnancy. 1, 2, the most common cause of ectopic pregnancy is pelvic inflammatory disease. Adding on to that, what is the most common cause of pelvic inflammatory disease? Untreated gonorrhea and chlamydia infections, not my opinion. And then lastly, or to add tubal ligation, let me show you what this looks like. Tubal ligation, this is not a common procedure anymore. We just remove the whole fallopian tube now. But what we used to do is ligate. Ligate means to tie or to cut, really. And so what we would do is you would put like clamps, or you would just you would put clamps essentially here. And then this is like a form of birth control to where the egg can't make it to the uterus and sperm can't make it here to get it pregnant. And so what happens sometimes is these ligations or these clamps will fail, and so that you can still get pregnant with that, by the way. And so now what we normally do is we just remove the whole fallopian tube because you have a risk of fallopian carcinoma or cancer if you leave parts of it. So most gynecologists will just remove the whole fallopian tube. Lastly is an intrauterine device, and so I could draw for you what this is. So if you might know that copper is used in intrauterine devices, and so what we'll do, what doctors will do, is they'll stick a device up through the cervical opening. This is a form of birth control, and it's like a copper T, or it could even be, and this is like a form of intrauterine devices. And so basically, this makes it to where you can't get pregnant. Okay, it causes chronic inflammation of the uterine wall to where you can't get pregnant. Very effective. In fact, besides abstinence, the single most effective form of birth control. Okay, but it comes with all its issues along with that. Okay, and so this is called an intrauterine IUD, intrauterine device. It's usually copper, and these can fail. These can fall out or just not work. And so they're changed every 5 to 10 years. So that's kind of the cool thing about them and why women like them, is because it's like a set it, forget it. You set it, and then you're essentially not going to get pregnant for 5 to 10 years. And if you want to get pregnant, the doctor will pull it out and you can get pregnant. So that's the idea of these, okay? Now, that's ectopic pregnancy. Very, very high. In fact, the single most high yield on this lecture. You will be tested on this. I promise. So again, how does it present? Unilateral. And to add, it can be unilateral abdominal pain. So think about it. If that baby implanted in the patient's right fallopian tube, they're going to have right-sided abdominal pain, okay? And so that's something to be aware of. So it can be unilateral or just lower abdominal pain of a woman of childbearing age. Usually they have missed their period. They'll usually tell that to you in the vignette. They can even tell you in the vignette that they are positive on a pregnancy test. You can still get positive on a pregnancy test with this. Not my opinion. And they can have vaginal spotting, which is where you have like a little bit of bleeding through the vaginal opening, peritonitis, extreme lower abdominal pain, and signs of shock in late stage, right? So as they bleed, you can end up with shock. And so this is a true surgical emergency. All right, moving forward. Vaginal bleeding. This is like 80, 90% of a gynecologist's practice because it's a common complaint. Okay, and so never assume an emergency call for vaginal hemorrhage from normal menstruation. And I would agree with this. You need to have a high index of suspension. In fact, I would be willing to bet. I need to look this up. That if you were to take a hospital, right, like a big old hospital here in McAllen, Texas, who do you think gives the most amount of blood? The trauma surgeons, the ER doctors, or the gynecologist? The gynecologist. It's the gynecologist. They give a lot of blood because women can bleed and bleed and bleed and bleed and bleed, and they lose so much blood they become anemic and shock, and so they can die. They can die from blood loss. And so, when I was doing my OB-GYN rotations, we gave blood like every week to multiple patients, and so this is a very common thing. They just bleed a lot, and so where I'm trying to get with this is never be like, oh yeah, she's 22-year-old vaginal bleeding, it's her period. No, 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 you're not a gynecologist, neither am I, and so just don't assume that these are true. Don't undermine vaginal bleeding. This can, will, and does kill people. I promise. Very lethal. And so I'll just help you out. Some of the units of measurements we use in EMS is you could ask them, how many pads are you going through? Okay, men, if you don't know, pads go on the lining of underwear, and they're like absorbent pads. And so the woman will bleed, and the pad absorbs it. Well, these can hold, I don't know the exact number, a large amount of blood before they get saturated to where they can't hold anymore. And so, if a woman tells you like, oh, I'm going through 10 to 12 pads a day, that's too much, way too much. It is severe bleeding. And so that's sometimes something a way we'll ask that, because if you ask, well, how much you're bleeding, you want to quantify that. So you chart. Patient reports she's soaked 10 pads in the last 12 hours, or whatever. And so they'll tell you, it's a question to ask. Now tampons, men, are a device that go into the vagina, and they're absorbent. Okay, and so they'll absorb blood as it's released from the uterus down through the cervix into the vagina. Now, again, any vaginal bleeding during the third trimester is a serious emergency. Women should not bleed late in pregnancy. A little bit of bleeding during pregnancy I wouldn't say it's normal, but it can happen. And so you have these two pathologies called placenta previa. We'll talk about these in our obstetric chapter, and abruptio placentae. And so I want to explain to you what these are right now. This has its own chapter, but basically this is where you have problems with the placenta. I'll just draw it really quick. So if this is the uterus, what happens is the placenta is this like connection between mom and the baby. And they'll go to umbilical cord, and let's just imagine here's a baby in here, right? Okay, and so here's the umbilical cord, not drawn to scale. And so what happens is you can get a detachment of this abruptly, and that's called a placenta abruptio, or abruptio placenta. And so that's a medical emergency. It's painful bleeding in the third trimester. You could also get what's called placenta previa, and that looks like this. Instead of the umbilical cord being up here, you're not going to be tested on this. I'm just drawing this for you now. I don't know why. But you will be tested on this eventually. This is where if this is the cervix down here, remember the neck, the cervix? What happens is the placenta implants down here, or it's shifted down here during pregnancy. So you'll see the placenta previa means you can preview the placenta. You can, if you were to do a speculum exam or a cervical exam, you can see the placenta. And so that's called placenta previa. This is painless bleeding in the third trimester of pregnancy. Both are emergencies, both are issues, but that's just kind of a way to draw that out. Now, and again, this does show up. We're just going to talk about it in another chapter, so don't think like, oh shit, that was too quick. We are going to talk about this again, I promise. And so, cause of vaginal bleeding, again, onset of labor. So you can have what's called the bloody show, where they'll expel a little bit of blood. This is fairly normal. Rupture of an ectopic pregnancy, PID and other infections can cause this. Any infection can cause this. Trauma. So again, if you were to take a baseball bat to the uterus, or even sexual trauma, extremely rough sex. In fact, not my opinion. The last slide, they talk about fisting, vaginal fisting. You can get trauma to the vagina, or to any of that area, and it can cause bleeding. So any type of trauma. including sex, rough sex, or any sex really. Lesions from previous surgeries or disease processes. I would go a step further. The most probably in older women, the most common cause of vaginal bleeding is going to be like polyps and uh, endometrial tumors, which are not always cancer, but you can get that. That's probably the most common cause in women that are older. Now, there's this condition called endometritis. Pay attention to how these are spelled. Endometritis. And so this is referring to the endometrium, the muscular layer. Okay, and so this is inflammation of the or irritation of the endometrium. It's most commonly caused by an infection, usually by STIs, chlamydia. Again, chlamydia, gonorrhea. These are probably the more common culprits. It says that here, and it's treated with antibiotics. And so, how this presents is a lady with lower abdominal pain, fever. They could have a little bit of bleeding, white, pussy discharge. I should say purulent discharge from the vagina. And so, if left untreated, it can lead to septic shock or cause spontaneous abortion. And so, if a woman is to get pregnant while having a concurrent chlamydia gonorrhea infection, you can get endometritis, and this can lead to a spontaneous abortion. A spontaneous abortion, again, is different from an elective abortion, where the woman will spontaneously, not by choice, they'll just abort the child, so they'll miscarry. This is, again, spontaneous abortion is the word for miscarriage. And so that's something to know. And so, again, this would present with lower abdominal pain and fever. Not to be confused with a condition called endometriosis. Now, see how these are spelled similarly? They're not the same thing. Endometriosis, is where you get this. Remember the endometrium, this inner layer? Excuse me. Where you get this inner layer. Sorry. I'm dying today. Where you get this inner layer of the endometrium. So remember, this is like blood products, essentially. It's kind of like a bloody tissue. For whatever reason, it grows where it's not supposed to grow. So we know that it's normally supposed to grow on the inner layer of the uterus. But in endometriosis, this inner layer can grow like in the abdominal cavity. It can grow on top of the uterus. It can grow in the fallopian tubes. It can grow down here. It can grow in the cervix. It can grow over here in the lungs. Endometrium can grow this endometriosis can spread to the lungs. And so it can grow in the brain. It can grow anywhere. And so this is really painful, okay, because you have blood outside of where it's supposed to be, and so you can get peritonitis and all these issues. And so what you'll see, the hallmark, so I'll just read this. Endometrial tissue grows outside of the uterus. So this is like the stuff that a woman would bleed, but it's growing where it's not supposed to grow. It's growing on the outside, so where it's not supposed to be. And so you can imagine this tissue builds up because of the hormones, the surge in estrogen and progesterone, but it has nowhere to go. So when it sheds, it just stays there. It causes scarring. It causes all these issues. And so it's very, very painful for women. It causes huge infertility, huge risk of infertility with this. And so it's one of the leading causes of infertility in women. 30 to 50% of infertile women have this condition. So I wouldn't say it's common, but it's the most common cause of infertility probably. And most common complaint is pain generalized in the lower back, pelvic, and abdominal region. And so it's cyclic pain. So as like the middle of their cycle, as this grows, this endometrium grows, where it's not supposed to be, it causes pain. And so this can be debilitating for women. I saw ladies in the OBGYN clinic it is sad. There is treatments for this, but the treatment for it, unfortunately, is to induce menopause. And so you don't necessarily want to do that to a 30-year-old lady who's trying to have babies. And so it's just this huge issue. You can surgically remove this sometimes if the surgeon's brave enough. But again, it causes scarring, so the surgeries become difficult. And it has a high risk of recurrence to where you can remove it now, but a year from now, it may be even worse. And so there's just all these issues with treating this. But endometriosis, one-liner, the endometrium, which is the stuff that lines the lining of the uterus, the inner lining of the uterus, plants somewhere else that it's not supposed to be. High risk of infertility. High risk, you can even see this with ectopic pregnancy if they even get pregnant. And so just know that it's very, very painful. Okay. Now, this is out of order, but there's something called postpartum eclampsia. And so the word eclampsia means seizure related to pregnancy. We'll just stick with that. And so basically, after a baby is born, the mother is at risk for eclampsia after several weeks after the birth. And so seizures and hypertension in women who recently delivered a baby is a sign of postpartum eclampsia. And so if they tell you, 32-year-old lady had a baby 4 weeks ago and today she's having a seizure and she's hypertensive and blah, blah, blah. It's called postpartum eclampsia. This is a rare disorder, actually. But there's several drugs paramedics can give. This is a life-threatening emergency because they could continue to seize and have brain damage and hypoxia. And so you'd want to call for paramedics if you were to get this vignette. Now, sexual assault, most victims are women. Now, I should say they can be men and children, so be aware of that. Men can be sexually assaulted as well by men or women. And so provide compassion and transport. A few things you should know, some patients will have multi-system trauma and need treatment for shock. One thing I'll say is the general rule of this is as gross as it is for the patient, you don't want them to remove their clothes, shower, douche, go to the bathroom, wipe, anything like that, because that's evidence. And so if they were to remove their clothing for whatever reason, it would need to be placed in a brown paper sack, not a plastic sack, but evidence of like that is placed in brown paper sacks. It would need to be documented. There's no need for a physical exam at this point, especially of the genitalia, unless there's like severe bleeding. And so that's just something to know, okay? Just be compassionate on this. One thing to say is paramedics and EMTs are not forensic examiners. We're not detectives, so knowing a lot of the details and hows and whys are very traumatic to probe the patient on that. Really, typically, you need to leave that up to a trained expert. You are not one of them. You received one slide of this in EMT school. There's specialized nurse called sexual assault nurse examiners that have a lot of specialized training. This is all they do to deal with this, and then, chain of custody and evidence and swabbing and collection of evidence and testifying in court, and so blah, blah, blah. Anyways, you need to know also, there's a SANE nurse at hospitals that will treat these patients. And, actually there's a new Texas law. Every emergency room in the state of Texas has to have access to a SANE nurse. And so I think that's a good law. It used to be only the big hospitals. And so there was some fallout where evidence wasn't collected properly. And so now there's a new law that they have access to one of these sexual assault nurse examiners. And so, just be compassionate. There's a call that sticks out in my mind. I ran a lady that claimed to been raped, and then, through follow-up, it actually wasn't true. But, it doesn't matter. I'm not there to judge her or help her. I was just compassionate and took her to the hospital. It's still extremely sad. So, anyways, children, one thing I'll add, children that are sexually assaulted, it is not our job to let the parents know that we know. What does that mean? 4-year-old lady, girl, vaginal bleeding. What do? You play dumb. Oh, okay, yeah, we'll take her to the hospital. We'll take good care of her. Yeah, blah, blah, blah. That's not your job to choke slam the father and say, how did this happen? Okay, as bad as you may want to. We don't do that. We just provide compassionate care. And this is where I've said this before in this lecture series. You have to play dumb. And they can't know that you know. You got to get the patient to the hospital to where the authorities can intervene. And, I will say, too, sexual assault is mandatory reporting. To where you're obligated to report this, especially of children and the disabled. And so what does that mean, mandatory reporting? It means that you report it, not your partner, not the nurse, not the doctor. You report it. It's mandatory reporting. And so if multiple reports get filed, that's fine. But just be aware, this does happen, unfortunately. So I'm just dwelling on this, but just be aware, this is actually a fairly common complaint, okay? And so to recapitulate, I won't recapitulate, I've said it enough on there. Now, moving to patient assessment, one thing I want to have you know is I've been in EMS for 9 years. It is exceptionally rare to do a genitalia exam, especially of the vagina. And so if you are going to do it, you need to have a chaperone present, preferably of the opposite sex, and they should be doing it. And so there needs to be 2 people present if you're going to inspect, not palpate, not speculum, nothing. Just inspect, meaning only with your eyes. We don't use our fingers. We don't use any other sense. It's just your eyes. And so what that looks like is A, gaining consent. Hey, ma'am, is it okay if I take a quick visual inspection of your genitalia? It'll be very quick. We will cover you immediately for privacy. No one can see in or out of the windows. Keep in mind that ambulance windows, if you open that up, people can see right to where you're looking. And so you may need to cover those windows or black them out. And so you have to gain consent and then inspect. And so this is a very quick inspection. Okay, it's not palpation. There's really only two scenarios, which we'll talk about in a different chapter, where you would ever insert the fingers into the vagina, which we just don't do. Okay, and so the reason I'm saying this is people have went to prison for this, and so be very careful and mindful. You need to gain consent. You need to have a chaperone. You need to be very, very cautious with this. Very professional. This is a sacred privilege that has been granted to us by generations prior to us, that have earned the trust of our patients to be able to do this. And so a patient can refuse this. And so if a patient is pouring blood out of their perineum and it's just soaking your stretcher and they say, no, you can't look, do they have the right to refuse you access to that? The answer is yes. And so patients have the right to refuse any part of your treatment. So don't get sucked into that on a question. If they say no, the answer is no. And so obtaining an accurate and detailed assessment, a thorough patient assessment will help determine how sick the patient is, whether life-saving measures should be indicated. And so gynecological emergencies involve large amounts of blood and body fluids contaminated with communicable diseases. So again, be careful. There's a lot of STDs that can be transmitted through this. And again, this is why we standard precautions, universal precautions, where we assume that all body fluids are infectious. Okay. I'm telling you now, if I'm going to a baby call, I am gowning up. Okay. I'm putting on shoe covers, face shield, gown, eyes, everything to make sure that you don't get splashed. They're very bloody and wet. Okay. And so all information you're trained to contribute to the assessment of your patient, especially your patient's overall health. Again, scene safety can be an issue, especially in the instance of sexual assault or child's death. Emotions can run very high. And so you, of course, have to get the MOI and the nature of the illness. Okay. And so first, we form a general impression. If you're called to a priority 1 sick person, and in the notes it says, patient has vaginal bleeding, you walk in and they're, pouring blood and, they're pale and cool and semi-conscious. You're like, yeah, their patient's in shock. They're in hemorrhagic shock. And so just be aware of that. And so if the patient has a weak or rapid pulse or the pale, cool, or diaphoretic skin, you're going to place them in a supine position. The shock position may even be appropriate. You're going to cover the patient to keep them warm. Remember, as you lose blood, your body temperature can drop, so we need to maintain body temperature to maintain homeostasis and metabolism, and we provide rapid transport. Now, all of these conditions I have named to you so far, there's very little a paramedic or an EMT or even a physician in the field can do to fix these. So they need rapid transport to a specialized doctor to fix this. So load them up, go to the hospital. These are not stay in place other than childbirth. These are not stay in place. These are rapid transport to the hospital usually. So of course we'll do a good thorough history. This is where almost all primary assessments will take place is a history. And so the gynecologic emergencies often have the same signs and symptoms of emergencies of other abdominal organs. This is what it's talking about. So, a patient with right lower abdominal quadrant pain with fever and you would think, oh, that's appendicitis. And a woman, you could be thinking, oh, this is a tubo-ovarian abscess or an ectopic pregnancy or, ovarian cyst or, endometritis or PID or whatever. And so these are all things to be aware of that in a woman, you have to add those differential diagnoses to your list of differentials. And so ask the patient about previous episodes, determine the nature and extent of the problem. How long has this been going on? Has this ever happened before? Have you seen a doctor about this? Do you take any medicine for it? Have you ever had surgery for this? Blah, blah, all that. And so ask the patient about any gynecologic conditions. Again, what is the first day of your last menstrual cycle? Have you ever had any surgeries? Do you still have all your parts, right? So, have they had an ovary removed? Have they had a partial hysterectomy? Whatever. Have they had a cervical cerclage? There's a lot of different surgeries that can take place here, okay? Consider the possibility of pregnancy in any woman of a childbearing age, even if contraception has been used. I would add to this, a woman could say, like, yes, I only have sex with my husband, but we wear condoms and we are on birth control. There is still a very, very slim chance, even if they were fully compliant with those, that they could still be pregnant. Again, the only perfect form of contraception is abstinence, having no sex. And so that's something to be aware of. Childbearing age is between 8 and 60. I've said that. Now, secondary assessment may be performed on scene or en route to the hospital, or not at all. So you may not have time. And so I've seen that on test questions where, like, when that can be an answer, is you could not do it at all if you don't have time. And so physical exam, approach the patient with a comforting attitude, maintain privacy, and I can't stress enough the back of the wall of the ambulance, you can see through those windows. And if someone were to spread their legs and you do an exam, then I mean, you could see straight through those windows into their genitalia. So that needs to be considered. So focus the nature of the illness on the patient's chief complaint. So what does that mean? If they're complaining of vaginal bleeding, you probably don't need to do a full cranial nerve exam and stroke assessment. You know what I'm saying? So that's just like a kind of a weird example. Assess the patient's vital signs. I can't stress enough, I've said this before, vaginal bleeding can cause severe, profound hemorrhagic shock. Okay, so be aware of that. UTIs, urinary tract infections, STDs, STIs can cause sepsis, septic shock, a form of distributive shock. So be aware of these issues, okay? Note color and the amount of bleeding and discharge. How do we do that? The woman will tell you, it's bright red blood, or what's actually pretty common is the blood will congeal in the vagina and it'll cause clots, and they'll say, I'm passing clots. And so these are like purplish clots, like gelatin, like clots of blood. And so that's something worth noting as well. If they're telling you have a bunch of blood clots, that's something to know. Okay, it changes kind of your differentials. I mean, if it's bright red blood, it's arterial blood. But if it's like a darkish blood or oozing blood, or it's blood clots, it's probably not arterial. Okay. Now the interventions, we have very few interventions, and I said this, they can be done. It doesn't matter if you're a doctor. So we treat hypoperfusion or shock, right? So, supine position, recovery position, keep the patient warm, oxygen if needed, rapid transport, right? Keep the patient warm, supine, provide supplemental oxygen, and transport promptly. Now, en route to the hospital, you're going to keep rechecking your primary interventions. Is this working? Are they getting better? Are they getting worse? Do I need to turn up the oxygen? Do I need to turn it down? Do I need to turn off the air conditioning? Blah, blah, blah. All those things, okay? Communicate all relevant information to the receiving hospital. Carefully document anything, especially in the cases of sexual assault. I would say also carefully document your physical exam and who was present when you were doing it and how it was performed, okay? Especially if you're doing a genitalia exam, that goes for males and females. Maintain the patient's privacy and modesty as much as possible. Again, they can refuse any part of this. Gain the patient's confidence by communicating appropriately and being professional and answering questions honestly. You could use sanitary pads. Again, these go on the external of the genitalia and to absorb the blood. And so place the patient on the left side. We've talked about this in class extensively. Remember, the inferior vena cava, this is my right, is on the right side. And so if you roll the patient to the left side, you lift a lot of weight off the inferior vena cava, so you get more blood return to the heart that way. Treat any external lacerations, abrasions, and tears with sterile compressions. This is external, okay? Vaginal lacerations are pretty common, especially in childbirth and sexual assault, sexual trauma. And so, but we don't treat that with, we don't pack the vagina, okay? Under no circumstances should you pack or place dressings in the vagina. Do not pick that if that's the answer choice, and don't do it in real life. Okay, it's wrong. It's not the standard of care. Consider the possibility of pregnancy. Be prepared for a possible miscarriage. Now, if the patient miscarried, a 12-week-old fetus, the best thing you can do is gather that and transport it. Sometimes you could, if it's possible, you could gather that and transport it to the hospital. Sometimes they'll do like a pathological examination on it. I've had it before where they flushed it prior to me getting there, and I'm not saying that to be gross, but the patient flushed it in the toilet prior to us getting there, and so we just transported the patient. And it's not like you can get it back at that point. And so, again, this is the treatment of pelvic inflammatory disease. The most common causes of PID are gonorrhea and chlamydia that are untreated. Remember, only half of women that have those infections will know they have them. They'll have symptoms. And so, but it can progress, and where you'll get is lower abdominal pain, fever, vaginal discharge of any color. Usually it's a white discharge. And that's the word, dyspareunia. And this is where you have a pain with sexual intercourse. The patient will generally walk doubled over and guarding with the abdomen. The reason for this is peritonitis. It hurts. And so a hallmark of peritonitis, besides what I told you earlier, rebound tenderness, where you let go and it hurts, they'll bend over because that it takes tension off the peritoneum, so it hurts less. Place the patient in a position of comfort that may be with them, allowing them to bend over and transport them. Now, ruptured ovarian cyst, again, that's how this can present is with sudden onset of severe lower abdominal pain. Typically, when they rupture, it's severe pain, and it's it's sudden severe pain. And so, watch for that in vignettes. If they say, "Oh, it was sudden severe," lower abdominal pain that radiates to the back or the lower abdomen, unilateral right-sided pain radiates to the back, you need to be thinking that's probably a ruptured cyst. There may or may not be vaginal bleeding. It depends. Ectopic pregnancy, again, this can be lethal. It's a true surgical emergency. If it ruptures, you can lead to hypovolemic shock, hemorrhagic shock. And so monitor for impending shock, including orthostatic vital signs. What are orthostatic vital signs? This is where the patient's heart rate will increase and their blood pressure will decrease, going from like a sitting to a standing or from a lying to a sitting position, to basically where you're moving them up a position. Their pulse rate will go up and their heart or their blood pressure will drop, and this is a sign of hypovolemic shock. You can also get this in dehydration, right? So if someone were to poop or have severe vomiting or severe dehydration from sweating or fatigue or whatever, you can get orthostatic vital sign changes, and that's what that is. Okay, so transport them to the hospital. It's a true surgical emergency. Vaginal bleeding. Now again, some patients may experience menorrhagia or heavy vaginal bleeding, and so always assume bleeding during the first or second trimester might indicate a spontaneous abortion or miscarriage. Remember, those words are the same. Third trimester bleeding is a serious emergency. The reason it's a serious emergency is you have to wonder, is the baby getting blood still? If the blood supply to the baby's been cut off, then the baby's going to die. And so, again, this is like a true emergency when that happens. And so you'd inquire about the onset of symptoms, okay? Now, sexual assault, this is one of the last slides, can take form in many ways, okay? Again, this can be men raping women or assaulting women, I should say, and men raping men and women raping men or whatever the direction. It can go any direction, okay? So keep that in mind. And so whenever possible, a female rape victim should be given to the option of being transported by a female EMT if that's possible, okay? So like I had several female partners, they were great. And so in fact, they were so great. If there was like a OB or gynecologic complaint, they'd be like, you know what, I'll take this call, I got it. And they would just take it, and I would take the next 2 calls. And so sometimes for the patients, that's their preference, girl talk, they hang out in the back and put the patient at ease, especially in the form of sexual assault. You have to worry, as a male, you have to think that they probably don't want to see another male, okay? And it's not your fault, you didn't do it, but that's the concern, that a female who's been sexually assaulted by a male may not want to see or be in close contact in a confined space, i.e. the back of an ambulance, with another male. So that's kind of the idea behind that. Okay. Limit any physical exam to a brief survey for life-threatening injuries. One thing I'll tell you, like a general pearl of wisdom, is I'll take these patients' vital signs. If they're stable, I usually don't take them again. Or certainly don't leave them hooked up to the monitor. It's you don't want to like tie them down with like the cords of the monitor and like the pulse ox and all that. If they're stable, you don't need to monitor them continuously or interrupt through the transport. So that's just kind of a customer service, like a good thing to do. Don't tie these people down. They've been through a lot. Okay, and so first issue is the medical treatment of the patient. Second issue is your psychological care for this patient. Again, compassion and empathy; those are important. Have a responsibility to preserve evidence. Remember, you don't want the patient to douche or shower or urinate or defecate or change clothes or underwear. If they have done that, you should obtain those clothes with gloves and put them into a brown paper sack or hand them over to police for evidence. Okay. Now, the patient does have the right to refuse treatment. That's something to know, but that you should encourage them to obtain to go to the hospital for care, especially for maternal injuries, STDs. I've talked about this in other lectures, but like, say the patient that got raped by a man that had HIV, or she doesn't know if he has HIV or not. There's prophylactic treatments that are very effective that can completely eradicate the chance of getting HIV if you follow them, if you've been exposed to HIV. Same thing for like most STDs. Actually, you can treat with a single dose of doxycycline. So like, if someone had unprotected sex or they're raped, without a condom or something like that, then you can take a single pill to prevent most bacterial infections. Right? So there's options, is what I'm saying. There's the options to prevent the STDs, STIs if you've been exposed. Now, so there's drugs that facilitate date rape. I've talked about this toxicology chapter. Benzodiazepines and barbiturates are very common, but for whatever reason, rufinol or roofies or GHB, which is a drug to treat narcolepsy to put people to sleep, seem to be the most common one that are tested, although they're certainly not the most common ones in the field. Alcohol could facilitate date rape. And so that's something to know. The patient could present with overdose, right? And so they could present with hypotension and bradycardia, so low blood pressure, low heart rate, difficulty breathing, seizures, coma, death. I mean, I've actually seen this before at Larry Joe Taylor. I've seen it twice, actually. I've seen people date raped. One lady, I think she might have died. We ended up having to intubate her. It's terrible. 19-year-old. So anyways, that does happen, unfortunately, in modern society. It's not just the movies. Like, that really does happen. As disgusting as it is. And so I thought it was a little odd your book put this in here because this wouldn't be particularly common, but it does happen. And so the sexual practice for vaginal foreign bodies. And so people can put very large dildos or live animals like a gerbil or a mice, or fist. There's a practice called fisting where they will shove a fist into the anal or vaginal canal, and as you can imagine, that was not built for that, and so you can get pretty severe trauma or lacerations or what's called prolapse, and so or they could rupture. So the colon can rupture, or the vagina can literally rupture, can like blow up, and like lice. And so there's obviously huge risk of hemorrhage with that, and infection, and prolapse. And so I was going to put a picture in here, but there's no need for you. You can imagine what I'm about to say. I mean, imagine in rectal prolapse, the colon is being pushed out through the rectum or through the anus. So like there's like this big red thing that's sticking out, and so that's a risk. And also you can get uterine and bladder and colon prolapse through the vagina as well, to where you can see this in older women, especially that have had multiple children vaginally, to where you'll see like the prolapse, like these organs will literally stick out of the vaginal opening, and a severe one. I've seen this in my OB rotations, and we do surgery to fix it. So what I'm saying is this can happen, and so you have to watch for hemorrhage and infection, and just know that can happen. Okay, now that's it for this. Something I probably should have started this lecture with is, and you may have snickered throughout this, is this is medicine. Some wisdom that I'd like to impart on you as a final thought through this lecture is, you have to really start viewing this as all folds of skin in a professional capacity. Understand, as humans, we're innately sexual creatures. As mammals, like I really do get that. But as EMTs and healthcare professionals and nurses and paramedics and doctors, or whatever your role is, this just becomes folds of skin, right? And so breasts are just folds of skin, and the labia is just a fold of skin. And you really need to try to desexualize this and be professional. And I know if I gave this lecture in person, there would be snickering, right, at the word vagina or penis and stuff like that. And I think that's a nervous tick of some people, and just realize that this is medicine and these are medical terms, and just be careful with that. And so when you do present to patients with this, is you just be professional and just use the medical term of a vagina or a penis or a testicle or a scrotal. Okay, that's what is expected of you. So again, it's a sacred privilege for us to care for these patients, and you'd be shocked with how willing patients are to discuss these issues with you and let you examine them and take care of them, regardless of your sex or who you are, as long as you're professional. And so keep that in mind. I guess that's kind of all I had to say on this lecture, so I appreciate y'all's time. And I think after this, we start trauma.